Well, good Friday afternoon to everybody out there in SADS Facebook Live land, coming from a little different location here in Hill City, South Dakota. My wife and daughter and I just saw the Crazy Horse Memorial, which is an amazing structure, going to be the largest sculpture in the world when it's ultimately finished. So I found our car, which I'm hidden in quarantine in for the next 40 minutes together with you. So welcome to SADS Facebook Live, episode number 34. And it's just a treat to have really a dear friend of mine, a SADS board member alongside with me for the last 14 years on the board, and just one of the giants in our field of pediatric heart rhythm care, Dr. Robert Campbell from Sibley Heart Center in Atlanta, Georgia. Robert, thanks for taking the time out and joining us.
I'm glad to be here.
It's really good to get to visit with you and with our listeners. Some of you have been with us from the very first show that we started in February. We started it because of this thing called Corona and COVID-19, and we're still in the midst of the pandemic. We're not done yet, so this COVID fatigue, you better get over it because we still need to roll up our sleeves, do all the right things, put the masks on. I had mine on in the restaurant just now, so we can do this, everyone. So hang in there. Remember, your genetic heart condition. Just saw a patient last week who was freaked out thinking that they were at great risk of having COVID-19 badness because of their long QT. And again, like we've said in February, March, April, May, June, July, August, September, and now October, our conditions, these genetic heart rhythm conditions, do not confer any greater risk than what my risk is or what an 18-year-old risk is who's otherwise healthy. So don't get worried about your specific disease and its intersection with COVID-19. Stay strong out there, everyone. But we're not going to talk about COVID-19. Instead, October is Sudden Cardiac Arrest Awareness Month. And we at the SADS Foundation, again, welcome to it on behalf of Alice Laura, our CEO. And if you haven't been listening, I'm Mike Ackerman. I forgot to say that, genetic cardiologist at Mayo Clinic. But for SADS, for Sudden Cardiac Arrest Awareness Month, we couldn't think of anybody better than our SADS board member, Robert Campbell, who is a dear friend of mine. Whenever I've had a tough question that I've wondered about in terms of the future of the SADS Foundation, what should we do? How should we do it? Is it the right time to do it? Why should we do what we're doing? The first person that I would call and that Alice would call is Dr. Robert Campbell. And he is the real deal to me. He's a dear friend. We're close enough in age that father figure, I guess, would have made him very young to have been my daddy, but he really means an awful lot to me. So, Robert, thanks. And why don't you tell SADS Facebook Live a little bit about your journey in this field of ours, and then I'm going to ask you some specific questions about sudden cardiac arrest.
Well, I think I had a very interesting journey. I have told many people throughout the course of my career that I think early on I felt like I had to apologize for saying I believed in fate and destiny, but I don't apologize for it anymore because I've seen it happen too many times. I remember the very first day that I walked into my cardiology fellowship at the University of Michigan in 1981, and the first day in the cath lab, all the techs were whispering behind my back. And I said, "What are you whispering about?" And they said, "You're the new fizz boy." I said, "Keep talking. I'm still listening." And they said, "You're the new fizz boy." And I said, "What is that?" And they said, "Well, you're the new electrophysiology fellow." So I had already been designated an electrophysiology fellow. Well, make a long story short, it seemed like a perfect opportunity to me. And I was actually pretty interested in it. So that was the introduction to electrophysiology. But that was a long time ago, back predated a lot of what we know about sudden cardiac arrest, a lot about what we know about these genetic cardiomyopathies, channelopathies, and even the cardiomyopathies, and predated ablation and ICDs and lots of things that we really sort of take for granted now. I became I went back to Atlanta in 1987, and I became chief there about 10 years later, that cardiology program. And I remember meeting Mike Vincent
Hmm.
at a meeting. I think it was American Heart Association, and he was presenting at a big session, and he was talking about long QT syndrome, and I thought, it sounds like that's really interesting, and I really need to know more about that. And I remember going up to him after the session, and I said, "Can I talk to you?" And he said, "Sure." And he was so gracious and actually, sat down with me and said, "Let me get your name." And so that's actually how I got involved with SADS. I mean, it seemed like something that I needed to do, but it was also something I was really pretty passionate about. And then, so became more involved with SADS, and of course, more involved with the channelopathies as a electrophysiologist and as a chief of cardiology. In 2004, we started Project SAVE. And again, very fortuitous, very much fate and destiny, because I'd been in a meeting in the morning, and Donna Highland, who was the chief financial officer of the hospital, now the CEO of the hospital, she said afterwards, she said that she'd been at a meeting, she'd been at a dinner party the night before, and unfortunately there'd been a case of commotio cordis,
Hmm.
7-year-old who didn't make it. It didn't really sound like there was a really very reasonable attempt to save him. Nobody knew what they were doing. And her question to me was, what are we going to do to prevent all these sudden cardiac deaths? And I said, well, I don't know if we can prevent them all, but I think the hospital needs to take ownership for education and awareness and advocacy. And, we need to do something. And literally, I went back to the office that day, and there was an undergraduate Emory student there. And he said that he was from Wisconsin, and did I know Stuart Berger? And I said, no, why? And he says, well, this student's best friend was a guy named Adam Limmel.
Hmm.
And and he was the one, so Project Adam was named for it. Adam then standing for automatic defibrillators in Adam's memory. And I'm going, this is just too weird. And she's asking, what am I
Wow.
supposed to do? And here's this guy that I don't even know who's come to see me. And so I said, well, no, I don't really know Stuart. And I said, why, is he a nice guy? He said, yeah. And I said, well, let's see if we can get him on the phone. So I called him and so now I'm hooked up with that. And then I remember meeting you for the very first time at one of the PACES meetings or something like that. And you give a really interesting talk about ventricular arrhythmia. And I thought, that's one of the best talks I've ever heard in my life. And I just needed to come up and introduce myself. And so we became friends and started working together. So a lot of things have come together to sort of bring us to where we are today.
Yeah, and Robert, you said as a fizz boy, you kind of have predated a lot of things and you've seen a lot of things.
Oh, yeah.
And I'm curious, from that flashpoint of sort of the birth of Project Save, the intersection with Project Adam, and then your last 14 years on the board of SADS, you know, take us through maybe a highlight reel of some of the 3 or 4 most impactful things that you've observed over these past 14 years with Project Save, Adam, and the SADS Foundation.
Well, I think probably in no particular order is I would still say I think that one of the things that's been most impactful for me personally is I would still use the word graciousness, and I think it started with Mike Vincent, is the ability for people that are on the board and the people that are involved in this care around the world, how free they are with their knowledge, how free they are to share and support and help establish best practices everywhere you go. There doesn't seem to be any proprietary ownership for anything that's going on. I can pick up the phone and call you and get help. I mean, almost instantaneously. We know people through PACES and different people that are very free to try to make sure that we can all do the best we can do in our individual careers, but also with our programs. So I think that's one. I think the other was I think the role of genetic counselors has really been important.
Hmm.
It's really been important. I remember when we hired our first genetic counselor, Heather McLeod, who's most of us know.
Yeah.
She had moved to Atlanta, and she was that role in Chicago, and she moved to Atlanta, and she's interested in a job. And I think actually Alice probably called and said, well, here's somebody you need to talk to. But it's really transformed what we do because they bring such a unique angle to what we do. I'm a different cardiologist than you are, Mike, and that expertise, actually enhances my ability to provide better care, and it certainly allows us to have a more a better, I think, a more informed conversation with our families and our patients. But it's really transformed our program. The other is, genetic testing. I even told a family yesterday in the office, I said, when it first started, I guess I was so naive that I thought that it would just answer this black, white, yes, no question. We would finally be able to take all these conundrums and we just solve it. I mean, we just do a test, we would just solve it. And it's turned out it solves probably about 10%, and it confuses sometimes about 90%, but we finally work our way through it. But it's certainly transformed what we do in the ability to identify other, concealed patients or clinically unaffected or undiagnosed, I guess is a better way of putting it, patients that need to be counseled and protected and informed. So I think those are some of the things. Obviously, ICD coming around and being able to actually do something for some of these patients that medicines don't treat. Those are probably the biggest things as far as I can think of.
Yeah, and it's really kind of incredible, isn't it, Robert? When you think about when we started doing our genetic heart rhythm clinics, it was largely pre-genetic counselors. It was even pre-genetic testing. It was pre-effective therapies, and sort of a mood out there in 2000 was that any time a patient got diagnosed with one of our genetic heart rhythm conditions, long QT, CPVT, Brugada, it was largely a death sentence, or it felt like a death sentence,
Yeah.
a spooky sentence for sure, for which we didn't know the why, and weren't confident in the what to do about it. And now 20 years later, it's not spooky. We can treat these diseases incredibly well for the most part. Still some exceptions. We can get genetic testing like with a snap compared to what, just 15 years ago, $5,000 and 75% uncovered, to now genetic testing is nearly free for most patients, with it covered by almost all patients. So complexity is there, isn't it, with interpreting the results and what exactly does it mean, but our ability to get the results, what a game changer compared to, just 15 years ago.
I don't know how many years ago it was, but I remember, I think we were probably having a board meeting, SADS board meeting in Utah, in Salt Lake City.
Yeah.
Remember, the conversation was change the name, because it's sudden arrhythmic death syndrome. And we said, it's really not a death sentence. And that can be the worst case scenario, but it's so uncommon now with the correct diagnosis and correct management. And so actually that prompted us to pick up the name stopsads.org too. But there was so much brand recognition with the name at that point. It was an interesting conversation.
It really was. Sometimes it used to be an interesting conversation at times. Sorry, with this trying to do it by phone, somebody had the nerve to try to call in at the same time. So here we are live. Well, I imagine most of our SADS Facebook listeners who are watching now, and I can see some of the names. Great to see so many familiar names, and your friendship, and feel like I know you. Some of you I do know you, and so welcome back. But they know SADS Foundation. They may not really know Project Save. Sort of lift up the hood and show to them kind of what's the nuts and bolts of Project Save and what's it been about, and like how many lives do you think Project Save honestly deserves the direct credit for truly having saved that life of that precious person?
Well, Project Save stands for Sudden Cardiac Arrest, Awareness, Vision, and Education. It started as a result of that conversation out in the parking lot with Donna Hyland that day in Atlanta, when she asked, what should the hospital do? How are we going to prevent these? We were fortunate enough to get a $300,000 Children's Miracle Network grant. We made an application with the hospital, and we got $300,000 to start that. And then literally an angel shows up, Allison Ellison.
Hmm.
So I did not know her. Her background was as a
Wow.
school nurse, and she was in the wellness initiative there at the hospital. I'd never met her, didn't know her, but she said, that sounds like a good job for me. And she came and joined. And again, what a good person to have, because she was very passionate about this. And as a school nurse, she knew everybody across the state. She knew everybody across the state. So that Project SAVE's goal, it really was sort of two-pronged. There's a primary prevention piece, which is basically emphasizing patient and family history to try to find those patients and families that are affected, those rare cardiac disorders that might put you at risk for sudden cardiac arrest. So we've not been on the front of ECG screening. That's not how we felt the best way to do it. We've really pushed this initiative about patient and family history. And I think we've had really good success. It's been adopted by the Georgia chapter of the American Academy of Pediatrics. So we now have, our cardiovascular risk assessment form that many of the pediatricians use in the offices. And with that, then when they identify somebody they think needs further evaluation, then they direct them to us. So we've used that for primary prevention. Then, of course, the secondary prevention piece of the emergency action plans, call 911. Bystander CPR, the early and appropriate use of an AED, and trying to demystify a lot of that.
Mm-hmm.
As you were saying, one of the major breakthroughs, AEDs are a huge breakthrough in terms of life-saving device, just like ICDs, but the other is just being able to do bystander CPR, and knowledge that for the first 5 minutes after a witnessed arrest, you can do compressions only, and how important that is.
Hmm.
Sort of took away a lot of the fear, I think, from most people, the hesitancy, the reluctance to even engage. So Project SAVE has been doing that. It's, when Allison retired, then here comes Richard Lamphere. I'd known Richard for a long time. He worked in our hospital system for a long time. He and I were friends and stuff like that. But he was applying for the job, and I'm going, gosh, I don't know. And when you sit down and talk to him, he says, well, his background was with EMT, and he worked with NASCAR, and he knows everybody around the state, because he's been involved in all of this, and he fit in perfectly, and it was such a passion for him, and he's taken it and run with it too. So really, Project SAVE's really been fortunate to have both of those coordinators, because they're the feet on the street. They're the ones that make all this happen.
We had Richard on our program
Yeah.
about a month or two ago. In fact, he did, chest compression only CPR training to all of our listeners, with the Staying Alive melody in the background.
Right.
And so, as only Richard can do. So you have had a great team to make Project SAVE successful. And you mentioned the A of SAVE, of awareness, and you have the risk assessment for the pediatricians. But with October being Sudden Cardiac Arrest Awareness Month, what are the critical, let's throw down the penalty flag on that item and put that patient family in the penalty box because we need further evaluation. What are some of those elements that if a school nurse elicits, or a family knows about, or the pediatrician elicits, whatever, that's the penalty flag, kind of like concussion protocol. We need to stop, we need to do a timeout, and we need to get this evaluated further. What's on your awareness checklist?
Well, from a family history standpoint, in no particular order, is the history of sudden, unexpected, unexplained death, less than age 50 years, and it's, you have to have the family take ownership for the detail. So that's the question, but then they have to go back and ask their aunts and ask their grandparents and get this information. The answer that I don't know is not an answer. That's just a cop out, but the detail is so important. And then being curious about furthering the detail. Another would be unexpected or very atypical exercise, or chest pain or shoulder pain. That's one that Richard has really pushed too, is to broaden it a little bit more, the shoulder pain, which can be sometimes myocardial ischemia related. The other would be unexplained seizures or syncope, especially at young age. And then also, taking the time to ask anybody in the family who has long QT syndrome or CPVT or HCM or any of these disorders, and And many times families will say, no, not that I know of. But again, the not that I know of is then the introduction to say, here's a list of questions that we want you to go to, basically almost like family reunion, and get the
Right.
details.
And that's
You
hugely
know,
important, isn't it? I mean, I think we sort of pass over taking a careful family history, but I'm thinking just as you said that again, the number of times where there was truly an opportunity to have saved a life if that family history item would have been noticed or would have been respected and acted upon, like you said, with the follow-up, here's some homework questions. And not that it was the family's fault, but I've seen times where the family history was well documented by us, our community of physicians and healthcare providers, but there was no sort of um, urgency assigned to delving into that story a little bit more, or taking a simple next step maneuver for the sort of the immediate circle of relatives to that suspicious death case. And I still think we have a lot of opportunities where if we would act on family history with a little bit more vigor, like you've been advocating for, gosh, as long as I've known you,
mhm,
we could save even more lives. And to me, there's an excitement in that, in the sense of that's a low cost opportunity, as opposed to some of the things that are very costly interventions.
mhm.
And what do you have any sort of family history fumbles that you've noticed that just sort of have made you pull your hair out as to why wasn't that item acted upon?
Well, I think it's easy to sort of disregard some things that you hear, or to misinterpret it, to say that somebody died at this age, and you're going, if you're not going to spend the time, and if you're really not curious and you're not thorough, it's easy to sort of disregard it, just saying, gosh, that's so unfortunate, I'm sorry, you've had to go through that loss. But yet that may be that just that one opportunity you've got to get your foot in the door there, and then open it up and find out what's going on behind it. You really just have to spend the time. And it's like the first office visit, you get one set of answers. The next office visit, you'll get more detail. The next office visit, you'll get more detail. And finally, then sometimes you may finally just find that right nugget that gives you the answer, or says, here's where we need to be going. I just think you have to be thorough. A lot of you do it too. These aren't one and done office visits. These are things that, and you may spend weeks and months doing everything you can and still come up saying, we don't know what happened. But that then means you don't discharge that family. You say, let's revisit this in a year or something like that, and see if we've learned anything further.
Right.
I
I
just a
just had
matter of
one.
being disciplined about it, I think.
Right. I think, we have so much work with our trainees, because just case in point, we just had one on Monday where, my trainee went in, took the family history, came out, and so here's the pedigree, and drew the pedigree well.
Mhm,
But then this 4-week-old's father's father, it just says dead at age 49.
mhm.
And that's it. I said, well, what were the circumstances? So we sort of accept, oh, I guess dead at 49 is something just to pass over. And it turns out that dead at 49 meant, well, so then he went back in the room and he said, uh, it was a heart attack. And I'm
Yeah,
sure you see that, right? So,
yeah,
oh, so then that trainee was satisfied that death was explained, and not, as opposed to saying, wait a second, anytime anybody of that age died, everybody called it heart attack.
right.
And it turns out it didn't take long to sort out that was a 49-year-old previously well, who then suddenly collapses in the midst of a heated argument,
Mm,
and no autopsy done, gets called heart attack. And even though the father's ECG looks normal, we then prove that we have long QT coming through the father's side, for
yeah.
which that heart attack victim almost certainly was long QT. And so you sort of have always been about saying, don't ever accept the first explanation as the explanation
Right.
in these unexplained sudden deaths.
Yeah, you have to just revisit it. I mean, we've learned an awful lot from what you've done, and others, with Mike Vincent, and people just, you know, it's just a matter of revisit it until it's completely understood. And it's still amazing how many times we've done all that work, and you're still left saying, I don't know, with molecular autopsy and with evaluating the entire family and things like that. It's frustrating, but it's a work in progress.
So become more aware of your family story. And if there's a story of concern, tell somebody about that story of concern. What about for each individual? What warning signs should they raise their hand about and say, hey, I think maybe that's me, and I ought to tell the school nurse that, or my parents that, or my family doctor that? Which warning signs? I mean, a lot of symptoms we can blow off and blow over, but which ones are sort of the please don't blow off this, you've got to tell somebody about this symptom?
Well, I mean, obviously, if you have unexplained recurrent syncope or seizure, that's there's an explanation. I mean, you could have a neurologic condition causing that, but too often, if you don't scratch hard enough, you don't find the cardiac cause of it. Unexplained drownings and things, or especially during emotional stress or with exercise. Those are some of the things that are probably one of the more common things that we see missed. Um, I think the other is that we see an awful lot of the sudden infant death syndrome, the sort of the autopsy negative sudden infant death, and that's a hard one to do
Hmm.
because sometimes it doesn't leave much of a footprint, and we don't necessarily always have autopsy material for which we can do postmortem genotypic assessment, but then trying to get in with the family. So there are those sort of repeating scenarios, swimming and exercise and emotion, where you just say, I don't know. That's just it. It can be something simple, but it also can be something that's more diffuse, and obviously puts a whole lot of other family members at risk given the genetics of many of these disorders.
And what do you tell them for the syncope story or the fainting? I mean, how do we separate the so-called wheat from the chaff of the normal fainter who does have recurrent syncope,
Mhm.
but it's really of no big deal unless they hit their chin on the way down,
Yeah.
versus the one where it really is there, it's the harbinger to sudden death. They're trying to tell us that they're doing torsades, they're doing a danger rhythm, and they may do an exit rhythm if we don't recognize this. What do you at say Project Save, and what do you tell them to try to distinguish the normal faint from the extraordinary faint?
Well, the normal faint is sort of the vasovagal faint. Typically, it's got a little prodrome to it before you pass out. There are warning signs. You may have visual change. You may lose your vision, or things get black, or you may have a lot of dizziness. You may lose your hearing even. The patient who's got sort of, you can, if they tell you the story, they can tell, I knew something was happening. I knew something. I have abdominal symptoms, or they may feel like they're going to throw up. Um, those that's a little different story than if you're just sort of boomed down. Just like I always said, if you look like you're running a 400-meter race and you just got shot and you do a face plant, that's a little bit worrisome. Now you can have an asystolic vasovagal faint, but typically that's not the only way you faint. If you've had an asystolic faint with no warning, but you may then also have, more typical pre-syncopal warning signs of dizziness and lightheadedness, abdominal discomfort, vision loss before that. But I think the patients that say, I don't remember, and they actually were terribly injured as they pass out, that's always worrisome. That's always worrisome. It may
Hmm.
be it may be vasovagal, but that's a diagnosis of exclusion right there.
Right, absolutely. They definitely deserve a full workup.
Yes.
Yeah. What as you think about the next 10 years, if you were to be putting on your weather forecast for the evolution of Project Save and of the SADS Foundation, what do you think we'll be talking about in 10 years in terms of the achievements? We talked about how we went from a spooky death sentence in 2000 to now calling ourselves Stop SADS because we fully expect to stop the tragedy,
Yeah.
to having in our sort of SADS mission, live and thrive,
Hmm.
because we expect you to live, not die, and we don't expect you to just live, but thrive.
Yes.
Where do you see us going overall in the next 10 years with respect to sudden cardiac arrest, preventing sudden cardiac arrest, living with sudden cardiac arrest conditions? What does your crystal ball show?
Well, I hope it'd be around a couple of things. One is I think that we'll be able to have broader awareness about it. So that's
Mhm.
we just need to continue to talk about this. It's almost like the seven cancer warning signs. You know we had talked here in Atlanta for many years, trying to work with somebody like Kroger's or Publix, one of these big, and have them help us. As you're walking out of the store, here are the warning signs for sudden cardiac arrest. So to make people more aware of these warning signs and be more curious about their family history. I think one of the problems is the way families are structured right now. When I grew up, I mean, all my grandparents and all my aunts and uncles, all my cousins, we all lived within a stone's throw of one another. And now
Right.
I don't live, I don't live within 250 miles of even one of my brothers or sisters. So we're all spread out. But I think that, knowing those warning signs and symptoms is important. The other thing is that I think that the genetics will finally get to the point, and this is a lot of the stuff that I've learned from you, is we'll probably get to the point where we realize maybe there's some of those, there maybe really are some low risk scenarios
Hmm.
where we can avoid medications, or we can have, the emergency action plan protection around you. Maybe you don't really need daily medications. Maybe you don't. But I think that the other is, I think that some of the innovations that are being talked about with, wider spread and more immediately available, emergency action plan responses, things like, it
Hmm.
sounds funny, like drones or systems of communication that will help bring an effective resuscitation to a victim almost instantaneously, and having more trained people. I do think that one of the things is we could probably do a better job making sure that people knew with a witness cardiac arrest, you don't have to do mouth-to-mouth resuscitation for the first 5 minutes.
Hmm.
It just seemed like that was almost a game changer. People, too many times people would say, I'm not doing CPR on that person because I don't know what I'm doing, number one. The second is I'm not putting my mouth on their mouth because they're a stranger and I don't know what I don't know. The other is, there was always that, though maybe those were the explanations. You're always afraid you're going to make things worse, or you don't know what you're doing. So I think that compressions only CPR is a story that we need to tell more, so that
Yeah.
more people will be willing to be trained and be willing to respond. Um, it sounds sort of ugly, but you can't kill a dead person. You can resuscitate somebody who's having cardiac arrest. You're not going to kill them in general. And if you fracture a rib, well, we can fix that. But
Right.
the non-response is the worst response.
Right. I think creating that army of first responders, and
Right.
I know we've talked about it, you and I, of how cool would it be if we, in the near future, hopefully it doesn't take 10 years,
Right.
have a high school requirement of chest compression only CPR and know how to use the AED. And because
Right.
it's this generation that's unbelievably tech savvy.
Yeah.
So grabbing the AED off the drone that just dropped it,
Right.
um, uh, is something that'd be pretty neat to have the next generation be sort of the lifesavers, with ability to be a rapid responder like that.
Hmm.
Hopefully, we won't take 10 years for that. But now in our last couple minutes, we'll go back to the future of now, and we'll link us back to COVID-19. And I'm sure your program in Atlanta has been inundated with ours, with kind of anxiety-filled questions from our patients, whether they are channelopathic patients, long QT, whether they're heart muscle patients, ARVC, whether they're your regular congenital heart disease patients. Maybe take a moment to take one or two of the most common questions that you and your team have been pulsed with during this COVID-19 pandemic, to give some insight or reassurance in these final minutes that we have together.
I think that one of the most common questions we get is, is it reasonable to go back to school? And how do families make those decisions?
Hmm.
Um, we said that, and then, is their child at greater risk because they have a heart problem, or are they at greater risk because they have a SADS type condition? My response has been that we don't really have any data that they're tremendously higher risk in general. They Nobody wants to get that infection, and so the things that we can do to prevent it are the common sense things that we're all doing. Wear a mask, um, keep the social distancing, um, and you know be prepared. But I don't think that I don't think it's unique. There's nothing really, I don't see anything really unique about our patient population, but of course they've got a pre-existing condition, so they're worried about all of that. And so I've
Hmm.
tried to reassure them that, the common sense things we're recommending for all of us is probably the best way to approach it. What are you telling them?
Same. I mean, I think it really is. Are you pleased as mom and dad with the logistics that the school system has arranged as if your child was normal? I'm trying really hard. And again, we just had it earlier this week where the family was convinced that their child cannot go back to school because of their long QT.
Mhm.
And there may be reasons not to go back to school in any given community. I just don't want long QT or CPVT to be one of those reasons because uh, I think in general we are hurting this current year of school children by
Mhm.
not being back into the school system.
Yeah.
Now, if the school's not ready and that community is on fire with the virus, well then yeah, of course, we don't go back to school for anybody. My daughter doesn't go back to school and she doesn't have a condition.
Mhm.
And that's like our school has decided it is virtual learning only right now because they don't feel like we just got another update this morning saying, well, we're not going back anytime soon because the numbers in our community are not going in the right direction.
Yeah.
And so I would want all of our families to do it based upon those reasons, completely independent of their child's condition, with maybe the one exception being our Timothy syndrome children.
Mhm.
You know, them, they are probably more vulnerable with their immune system compromise, but we really don't know. The numbers aren't
Mhm.
out there. But if we were to pick which of our SADS conditions to be the slowest to return to large gatherings, I guess it probably would be the Timothy syndrome kids.
Mhm. Yeah, I've talked with them and I said, basically the question about going back to school, I said, do you go out to eat?
Right.
Because they say, no, 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 we have groceries brought in. We do not go out to eat. And I said, well, that's a decision that you're making. You're making a risk benefit decision that you feel is in your best interest, your family's best interest. But you see some people that are saying they go out to eat. Well, is the restaurant that you like to go to open? And some of them will say, no, it's not open. And they've made a similar risk benefit assessment. And
Right.
they don't want to go out of business, but they also don't want to get everybody sick and they don't want any bad complications from an infection. So everybody's doing the same dance. How normal can we be, and how cautious do we need to be? And I think always changing. The formula is always changing. Even literally day to day, it can be different answer. But you have to find out where you're comfortable.
Yeah, so as we come to the end, just for SADS Facebook episode number 34, and all of you out there, I know if you were to put a hands together to thank Dr. Robert Campbell for all that he's done with Project Save, all that he's done for us at SADS Foundation. We are 14 plus years running together as a team. And as I said at the beginning of the show, Robert has been sort of the behind the scenes force of wisdom and force of guidance, that the timing is right to do this or the timing's not quite right to do that. And Robert, I have appreciated you so much. I value our friendship tremendously, and I look forward to a lot of great times ahead for you and me, for Project Save, for the SADS Foundation, and for all of the families that you and I care so very much about. Robert, I'll give you the final words, and thank you.
Well, I appreciate everything you said. I appreciate everything you do. You and Mike Vincent have really, with the whole team there at the SADS Foundation, have just made a remarkable difference for this patient population. I know they're very appreciative for what you've done to advance the field and to reassure families that there is a life with these diagnoses. So it's been a pleasure.
Yeah, all the best to you and your family. And for those out you in SADS Facebook Live land, can't wait to have you join us next Friday. We're going to have one of you join me and to hear your story. I can't wait. And then to have a drawing for an AED. And then we're going to take the questions that you've had today and next week for the balance of our time together. So tune in next Friday, same time. And until then, be well, everyone. Stay safe, stay corona free for as long as we possibly can. Blessings to everyone. Robert, thank you.
Thanks, my brother. Be good.
You too.